Well, thank you, Roxanne. That's a very kind introduction, and you're right. I'm worried about falling behind Rick. I always learn something at his talks. Now, he introduced himself as just a plain old clinical cardiologist, which I really find it hard to believe he's just a plain old clinical cardiologist. So I'm going to give you the transcatheter therapies from just a country surgeon from Texas. These are my conflicts of interest. So the agenda I'd like to talk about today is let's understand the data. And I'm going to stick to TAVR because I have a limited amount of time. I'd love to spend the afternoon talking about mitrals, but it's a whole new ballgame for me. I want to talk about what are our knowledge gaps and who should be considered for TAVR in 2020. So we all know the trials that are out there. We ran 2 extreme risk trials. Partner 1B was a randomized trial, the only randomized trial we've ever had in aortic stenosis, and there's a 20% benefit. We couldn't randomize in core valve, so we had a performance goal. But both these trials look good, and it got approved by the FDA. 2 high-risk trials for primary endpoints of all-cause mortality. Partner 1A, no difference, all the way out to 5 years. The core valve high risk, superior for all-cause mortality at 1 and 2 years, but by 5 years the same. And of course, that got approved by the FDA. Then we ran the intermediate risk trials. The intermediate risk partner 2A, it was no difference all the way out to 5 years, although there are the crossing lines. We've now moved to a primary endpoint of all-cause mortality or disabling stroke. And then for SIR-TAVI, we had a Bayesian endpoint that was non-inferior, but we've looked at the 2-year frequency statistics, still non-inferior, and of course that got approved. So if you look at high and intermediate risk from the surgical standpoint, if I'm going to do TAVR, what I'd like to know is that TAVR can show equivalent or better mortality. We had that. It either ties or wins. Hemodynamics, it won in these trials. Quality of life, it wins because it gets there faster. And durability, it's unknown. We're not going to ever know from the higher risk trials. Patient acceptance, clearly TAVR wins. And morbidity, well, TAVR tied or won for stroke, hemodynamics, atrial fibrillation, and transfusions. Surgery's won for PVL and for pacers in the self-expanding valve. And of course, you have to remember the mean age in high risk was 84 years of age, and the mean age in intermediate risk was 81 years of age. These are not young patients. And of course, there's 2 low-risk trials, and I'd like to talk about the trials and help you compare and contrast these trials, because this is where you need to understand the data. There's a Partner 3 trial, which was symptomatic severe aortic stenosis, low risk defined as STS less than 4, randomized 1-to-1, 1,000 patients between TAVR and surgery. We followed for 10 years, and of course, there's an LTI sub-study. The Evolute low-risk trial was low-risk defined as a predicted surgical mortality of 3% or less, randomized 1-to-1 TAVR surgery with revascularization as a substratification, again followed for 10 years and with a LTI sub-study. Now the endpoints are different. When you move to lower risk, there's going to be less events, so you have to either add patients, which costs the company more money. They're not enthusiastic about that. You have to add events, which is what Partner 3 chose to do, or add time is what we chose to do. Partner 3 chose the endpoint of all-cause mortality, all stroke, or hospitalization. At a 1-year endpoint, we chose to stick with what we thought was a more conservative all-cause mortality disabling stroke, but we wanted to move the time frame up by using Bayesian analysis, which would give us an early look for a potential early win at the data. It's important to understand the valves that were used. When Partner 3 started, the SAPIEN 3 was already commercially available. All the implanters had used this valve and were familiar with it. As we went through Evolute, we were looking through different generations of valves. There were still some core valve 31s, probably everybody's least favorite valve. About 3/4 were Evolute R, and less than 1/4 was the 3rd generation Evolute Pro. In Partner, you had to have transfemoral access. That was not true in Evolute, but despite that, 99% were done with the transfemoral access. Now, if you look at the baseline characteristics, they were surprisingly similar. You thought we designed these trials to look like each other. Mean age is about 73.5 to 74. Surprisingly, we now are 2/3 male. Remember, in high risk and intermediate risk, it was 50% female and 50% male. Now we've gone to 1/3 female, probably because just being female was an added risk in the STS database, and so many of these probably got called intermediate and treated commercially. And the STS was 1.9 across the board, surprisingly similar. The primary endpoint of all-cause mortality, stroke, or hospitalization met non-inferiority for Partner 3 and clearly met superiority with 15.1% for surgery and 8.5% for TAVR. Multiple sensitivity analyses were done. For our trial, the Bayesian predicted endpoint for surgery was 6.7%, and for TAVR is 5.3. That gave you a posterior probability of greater than 0.999. For those who need p-value, subtract that from 1, you'll get an approximate p-value of less than 0.0001. We too did a variety of sensitivity analysis, including a worst case scenario, and still maintained non-inferiority. Now we can also look at Kaplan-Meier curves because we have enough, even in an Evolute trial at 1 year, to look at good Kaplan-Meier curves. This is all-cause mortality. If you notice at 1 month, they're very similar, 0.4% for TAVR in both trials, 1.1 in partner 3 and 1.2 in the Evolute trial. Tremendously good results. But you go to 1 year, both TAVR and surgery have a lower mortality in the partner 3 than they do in the Evolute. Why is that? Partner 3 chose a lower risk group of patients. Once you survive your procedure, your long-term survival is based on intrinsic patient risk. So you got to be careful, even though the demographics look the same, they're not quite the same patient group. If you look at stroke, all stroke for partner 3 or disabling stroke, both of them statistically in favor of TAVR. Outside of partner 1A, we've never seen a trial where surgery looked better than TAVR. And in fact, if you look, it's very interesting in these trials, almost all the advantage is in the first month. It's a safety thing. Remember, embolic protection devices became available halfway through these trials. Marty, Leon, Mike Mack, Jeff Pop, and I talked about this. We decided not to allow them. We couldn't prevent you. I can tell you that in the Evolute trial, only 1.3% of people had an embolic protection device, and yet we still have a disabling stroke rate of 0.7%. That's what you'd expect for a bunch of 74-year-olds sitting in their living room for a year, doing nothing but watching TV. So these are astoundingly good results. Hospitalization, again, you look, it was superior for both partner 3 and for Evolute. And again, most of the advantage is up front. So if you take our data from Evolute and you look at all-cause mortality, disabling stroke, or hospitalization, similar to the way partner did it, doing it in a Kaplan-Meier at 1 year, we find it was superior to the 0.002 level. So we really had 2 trials that, if we use this composite endpoint, really had outstanding results. And in fact, if you look at partner, Jeff and I were worried that if it only won on hospitalization, we'd be in trouble. It was so outstanding because it really won at all levels. So really tremendous results. So if you look at the conclusions when Marty presented this, his conclusion was that TAVR was the preferred therapy in this low-risk patient group. Our conclusion was the same, but you have to remember this applies only to the population tested, so you need to know your trial data. So we now have this approved, and we're going to move forward. Now, Rick has just shown you this. You know, this was when this came out. For high risk, we moved to both surgery or TAVR as a class 1. When intermediate risk, TAVR is still class 2A because you really needed 2 trials. And this was put out 3 days before I presented Surtavi at ACC. Thank you, Rick. You could have waited 1 more week for me. But I do think that with the new data, in intermediate risk, we're probably going to move to this, and low risk, we'll probably move to this. And so now we're going to have TAVR across the board, and it's going to be very important as this therapy is propagated that we understand who is going to really benefit from this. This is what's happening in the U.S. right now. This was presented by Joe Bavaria at EATS this year. The purple line at the bottom is Bentals or root replacements. The green line is AVRs with coronaries. The yellow line is AVRs with other things such as mitral valves. The orange line is isolated AVRs, and the blue line at the top is all AVR procedures added together. The red line, of course, is TAVR. In 2015, we exceeded isolated aortic valves. In 2019, we will exceed all aortic valve procedures, and those are never going back. Now, the interesting thing, if you notice all aortic valve procedures, pretty much exactly where it was in 2012. This is not a zero-sum game. My overall surgery is not going down very much in my department. It's gone down a little bit, not much, but when you add in TAVR, we've tripled our valve volume in the last couple of years. So what are the differences in these trials? There's only 2 differences in these trials. The first difference is pacemakers. If you looked at the partner trial, there was no difference in pacemakers, 4% in surgery, 6.5% for the S3. And for the Evolute trial, 6.1 for surgery and 17.4. So we actually lost for pacemakers. That was exactly the same in the partner 3 trial. Now, if I look at pacemakers in the Evolute trial and I plot each individual site and the number of cases they did in the pacemaker rate, what you can see is that there is an experienced learning to this. In fact, my highest implanter, Hemodynamics, had a pacemaker rate of 1.9% for almost 69 patients. My site had a pacemaker rate of 5.6%. And part of that is how you implant this valve. One thing about S3 is it is a simpler valve to implant. None of us argue that. This is a little more difficult. You have to learn how to do it. And if you just do the normal LAO implant, you're going to implant too deep every single time. So you really need to remember your S-curve for both your valve and for your device. Or more importantly, just go to a double overlap. Overlap the right and left. That matches this double S-curve 95% of the time. And when you do that and you implant in a more REO position, you will think you're too high, but you're not. You're actually implanting in the right position. And we're in the process of teaching people this, and we're running a trial called Optimize Pro, where we're going to hopefully show that we can do single-digit pacemakers even in the self-expanding valve. Hemodynamics, for the first time, surgery won in Partner 3. As Marty pointed out, there were more big valves for two reasons. Number one, surgeons have become very cognizant that we were losing, so we wanted to work harder. Number two, there's more sutureless valves, which have more TAVR-like flows. We had 30% sutureless valves in Evolut. And lastly, there's only 1/3 women. It means there's 2/3 men, and men are bigger than women, so you're going to get bigger valves in there. So this was a little bit of a surprise to me. The hemodynamics of the self-expanding trial won at every time point, but that's really not a surprise. So that's the data. What are the knowledge gaps out there? Well, who was excluded? Well, we excluded bicuspid valves. The protocol excluded in Partner in syntax over 32, for Evolut, syntax over 22. But what did we really see? Well, the syntax in Evolut was 2. And the number of people with previous coronaries was 2%. PCIs, 12 and 14%. This was a really low-risk group of patients without much coronary disease. Now, whether or not this will be something we can translate into lower-risk patients with somebody with a syntax of 28 or 30, we don't really know that yet, and that's future study for us to do. So who was excluded after local heart team? As you know, these patients came in, they were seen by the local heart team, they had to meet inclusion-exclusion criteria and meet the anatomic criteria, and then the heart team would upload them to a national screening committee. In theory, with experienced people with screening, everybody gets accepted, but that's not what we saw. In Evolut, we screen failed 14.8% at that level, generally because their measurements, CT measurements, didn't match the IFU of the core lab. And in Partner, they screen failed 34%. 1/3 of the patients that were approved locally were screen failed at a national level. And so understanding who those people are is important. The problem is I can't go back and look at my screen fails. I can't ethically do that. They're not in the trial, even though that would be some of the most interesting data I could get, but I can't do it. We can't do it in either trial. Age, well, low risk. When I say low risk, I got a call yesterday from one of my cardiologists about a 54-year-old man who has aortic stenosis, and can I do a TAVR? And the answer is, of course, I can. The real question is, should I do a TAVR? So what does age? Well, in the Partner trial, less than 7% were less than 65 years of age. In Evolut, it was less than 6%, and less than 1.3% were less than 60 years of age. So again, as we go out there, we need to understand this data, because this is the best data we've ever generated. And safety is really the key difference in outcomes. Almost all the benefit was in the first month. TAVR is a very, very safe procedure. And one of the things that when surgery lost to TAVR in high risk, I went back and looked at every death. In fact, in all the Evolut trials, all the core valve trials, I've looked at every surgical death and every TAVR death. And I constructed instantaneous hazard risk of death curves. So for high risk, you had a high risk at the day of the procedure, it dropped to 30 days, and then for surgery, it went back up at 1 month and came down at 4 months and then stayed flat. Why did surgery go up at a month? Because our definition of mortality is death within 30 days from the hospital. We kept everybody alive 30 days and we sent them to an LTAC. They were old, sick people and they died in the LTAC. And then the ones that could survive 4 months survived on. And the only point where TAVR was superior was the 1 to 4 month. Everywhere else, it was exactly the same. So what happened when we went to intermediate risk? Well, the procedural risk dropped. It fell to 30 days. It stayed down. Why? These are healthier people. They're not dying in LTAC. If they go to LTAC, they live. And low risk? Well, now look. Now it's really low and it comes down. What's really startling? Well, the procedural risk in surgery dropped because you're going to lower risk patients, but it really dropped in TAVR because we're improving our devices, we're improving our technique, and that's going to continue on. I'm pretty much stuck where I am in surgery right now. I've been doing the same surgery for 35 years, and we're getting a little bit better, and we're changing our incisions, and we're tweaking this, we're tweaking that, but it's not going to change much, and TAVR is going to continue to go down. In fact, there were only 3 deaths in the early 30-day period for the Evolut trial. 2 of them were coronary occlusions, and 1 of them was an aortic dissection on a valve that popped out and got pulled back and dissected the aorta. All these should be very preventable. What were the surgical deaths from? Complications of surgery. As a surgeon, I've got to learn to eliminate that. Bicuspid valves, we all use the Sievers, type 0, no Raphe, type 1, 1 Raphe, type 2, 2 Raphes. I was taught that this was a young person's disease, but it's really not. Even the people in our high risk, 20% that came to us were bicuspid, but as we move into the lower risk population, it's going to be 50, 60% of who we see. There's some data out there. This is Raj's data from the TVT registry looking at S3, and he ended up with almost 2,700 matched pairs. What were the kind of highlights that you took away from that? Well, there were more stroke in bicuspids. There were more pacemakers in bicuspids. There were more conversions to open surgery, more annular ruptures in bicuspids. So I think we're going to treat bicuspids. We're going to get better, but this is a knowledge gap still. And in fact, if somebody comes to you and they're 55-year-old and they have a bicuspid valve, I would still find it very hard to say you should have a TAVR. We're pretty good at fixing that as surgeons. But there was no difference in one-year mortality and no difference in one-year stroke. So there's some hopeful signs out there on the horizon, and no difference in PVL, which is one thing that most of us worried about with bicuspid valves. How about hemodynamics? You know, Ramatula called patient prosthetic mismatch anybody that got a valve that wasn't as good as their aortic valve, which would be everybody. So we really don't use that. We use these indexed valve areas for moderate to severe patient prosthetic mismatch. We looked at high risk. We found that surgery had a whole lot more in the core valve high risk trial. And if you had severe patient prosthetic mismatch, it was a marker for death. Interestingly enough, we divided people up by annular size based on CT sizing, not surgical sizing, into those that would get a large, medium, or small core valve. And what we found is as you went from large to small, there was no increase in patient prosthetic mismatch for the core valve, but it soared in surgery. This valve is better than surgery, and the improvement gets better and better. The difference is more and more as you go to smaller annulus. And in fact, this replicated itself in the low-risk trial. This is Howie Herman's looking at TVT. There's about 12% severe patient prosthetic mismatch, about a quarter moderate out there. If you had severe patient prosthetic mismatch, even in a year, it was a marker for mortality in TAVR. Philip Peeberow's work looking at all the trials out there, all of them, both surgery and TAVR, had patient prosthetic mismatch, and each one of them, it was a risk factor for mortality. And in fact, if you were in the low-risk trial and you got assigned to surgery, I could tell you that at the end of a year, you had a 5.5 times greater chance of having severe or moderate patient prosthetic mismatch. And if you look at surgical literature, this is Fallon's work of almost 60,000 patients, 65 or over, a pretty good comparison. If you had any level of patient prosthetic mismatch, it significantly decreased your survival and increased your readmission for heart failure and reauthorization. Becky Hahn did these great papers. I'm not going to go over too much. What I will say is when you really look at these numbers, look at the DVI. If you really want to compare valves, forget the EOA, forget the mean gradients, look at DVI. And for any intraannular valve, it's going to be about 0.42, and for the supraannular valves, it's going to be about 0.6. I did the same data for Reprise because I ran that with Ted Feldman. It's exactly the same. And it will lead to more patient prosthetic mismatch in different valves. That's why as you get smaller and smaller, there is some advantage to one over the other. Once you get to about a 26 valve, it doesn't make much difference. This is Gorland's early work looking at the flow dynamics. Gorland generated this very interesting curve looking at aortic flow versus mean gradient. Normal flow is about 220 cc's per second, high flow is over 500 at different families. So if you see if I have an EOA of 1, at rest you're about 40. But if you exercise, you go up to 150. That's why these people die. And as you go lower, the spread becomes more and more because it's the square of the radius. And what you see is you really have to get to an EOA of about 2 before you can really exercise. And that may explain why when we did Surtavian, did a 6-minute walk at baseline, 30 days, 1 year, and 2 years. But of course, TAVR beat surgery at 30 days, but it beat it at 1 year and 2 years too. Better exercise tolerance. Durability, I'm not going to go over this too much. We've already talked about this. We have some randomized studies out there. We have some non-randomized studies. The data is very, very conflicting on both sides. Surgeons have been arguing this for 30 years, and we still haven't come up with what age. My rule is if you're less than 50, you're a mechanical valve. If you're over 65, you're a tissue valve. Between 50 and 65, there's no difference. Rick's paper says there should be shared decision making. If you're less than 50, you're biologic. If you're over 70, less than 50 mechanical, over 70 biologic. 50 to 70, no difference in survival. You ought to talk about it. This is what we know from surgery. We know there's a lot of early failures in surgery. We know that TAVR is doing pretty well all the way out to 5 and 6 years. This is Danny DeVere's work that really stirred everybody up. That's led to Capitano's definitions, which you've already seen for moderate. TAVR beats surgery for moderate. There's no difference in severe. In fact, when this first moderate came out for high risk, Tom Gleason, who was my publisher from UPMM, didn't even want to put it out because it made surgical valves look so bad. He said it's the data. So the surgeon, here's what I do. I look at the life table analysis versus the risk of a surgical valve wearing out. If you're 80, you're going to live about 10 years. Your valve has about a 4 or 5% chance. I don't operate on people 80 or above anymore if they have that anatomy for TAVR. 75, I think getting down at 75, you probably shouldn't operate on people if they have good anatomy for TAVR. 65, now we need to have a different conversation, but there's still some knowledge gaps that we need to fill in. Our population is becoming older. There's some estimates from Europe as to how many people will be added to the U.S. if we add intermediate fully, add low risk fully. And there's some estimates out of England about the untapped people with severe aortic stenosis. So I think it's a heart team decision. If you're 90 or above, you get a TAVR. If you're 80, yeah, you should get a TAVR. If you're 70, then you have to start thinking about valve and valve. But you know, some of these 70-year-olds are pretty active guys, and we need to think about that. But you know, certainly in mid-70s onward, I think that's pretty easy to do. In 60, it's really shared decision making. Patient prosthetic mismatch versus pacemakers, coronary access, which is very important, durability. Again, so how do we choose? The same things. For me, it's age, and how long is the patient going to live? What's their lifespan? What's their anatomy? There's certain anatomies that this excess calcification going down the mitral valve, those were probably eliminated from the low-risk trials. We still do real good surgery. And patient choice, yes, patients should have a choice. I'm not going to do anything that I consider bad, but you know what? If you're an adult and intelligent, and I tell you you're 65 and this valve may wear out, and you may get another one, and you tell me that's what you want, you'll take the risk, it's hard to argue that. So my final conclusions from the surgeon's perspective, demand for TAVR will increase. We can't stop it, we shouldn't stop it. The number of TAVRs will increase. We can't stop it, we shouldn't stop it. But we need to understand the data. And surgery will not go away, but it's going to become more complex, and having a good surgeon as part of your team becomes more valuable to the best programs. So my final thought is, love your surgeon.